So welcome everybody to the Heart Team Ring. So it's going to be a case-based tailored approach to treatment of mitral valve disease session, where we have multiple experts and multiple professionals around the table. They don't need any introduction, but I will introduce anyhow. So we have Felix Crede on the left, Dr. Rodrigo Lorero, Fabien Prats, Francesco Maisano, Georg Nickening, Alison Dakan, and Professor Falk, my previous professor, so important. The objective of this session is to really discuss cases head to toe in an open fashion. These are different patients, and with different complexity. We will try also to define complexity to somehow. We will try to discuss how to use to the full the spectrum of therapies which are available. And we will also touch base a little bit on secondary MR, which is still a matter of huge debate in the community. So without any further delay, I would like to introduce Fabien, because you are going to be the link between us and the audience.
Yes, Francesco. So we will see, as Francesco mentioned, cases. Some of them will be a bit complex. Some of them will be would show new therapeutic options for this patient. So there will be a lot of debate. But we want you also to ask questions if you have some of them regarding the complexity of the patient, the indication for the therapy, for the procedure, and to challenge us as well. I mean, the session is called the Heart Team Ring, so it should be a little bit of provocative and challenge between us. So ask your question by joining the link at Slido. Felix will see the question, I will see them as well. So we will try to give the audience really a big part of our discussion. And thank you very much also for standing up in the room if you want, taking the mic and interrupting or participating to our discussion. So Francesco, I let you open the session with the first case.
So Rodrigo Esteves Lorero is going to present us the first case, which is a case on primary mitral regurgitation. So we open officially round one.
So thank you so much for the invitation, dear colleagues. First case is about primary mitral regurgitation. I'm going to introduce the case, and we're going to discuss how can this patient be treated. So this is the conflict of interest. So our case is a 69-year-old male with cardiovascular risk factors, is hypertension, prior smoker. He's an obese patient with a BMI almost 33. He has COPD. He has moderate to severe sleep apnea with CPAP every day. He had a larynx neoplasm who underwent surgery in 2018, atrial flutter as well with ablation in 2021, and the patient was admitted to our institution due to heart failure. This is the echo, transthoracic echo. We can go through that in the discussion, but as you can observe, there's an eccentric jet with a patient with a posterior leaflet prolapse. That's quite easy to understand. Also, to consider the different possibilities, the coronary angiogram, we have a two-vessel disease case with a tight lesion in the middle AD after this long diagonal, and there's also a lesion in that like 2 OM artery, but with a small vessel with distal runoff. The right coronary artery was normal. By transesophageal echo, as you can observe, we have a central prolapse with a flail as well in the most lateral aspect of the P2. The prolapse height is 8 millimeters. Prolapse width was calculated 21 millimeters. That's quite out of the Everest criteria. So this is the patient, and now it's time to discuss how do we treat this patient. It's a surgical mitral valve intervention, transcatheter repair, transcatheter replacement.
So you should also have the possibility to vote for the best treatment or the treatment you would advocate in that patient, and we will look then at the results. So please connect to Slido and vote on the best option for you, so that we can really have a panel the audience deciding also on the option for this patient. So surgical mitral valve intervention would be the first option, transcatheter mitral valve repair, or transcatheter mitral valve replacement. So please vote and give your opinion on this.
So, but let's start a little bit of discussion here on the table while people are voting. Maybe we can influence the audience. Primary MR is primarily a surgical candidate. So, Volkmar, what is your opinion in these cases?
Thank you, Francesco. So I think that this is a very good candidate for minimally invasive mitral valve repair. What we should rule out is that really something needs to be done on the coronaries. So I'm not sure if an FFR was done, if these lesions that we see are really significant or not. That would be some information I would like to have, because it would eventually alter the strategy. So in theory, if these lesions are important, one could do a combined procedure. With regards to the mitral valve, if we leave the coronaries alone, it's a very straightforward mitral repair. Repair rate will be 98%, good long-lasting outcome. And you may argue that there is sleep apnea and that the patient may have an increased risk of postoperative long-term ventilation. But I think if we apply ERAS, enhanced recovery after surgery, this patient would be really fast extubated. And I don't see an additional risk that that would prolong his hospital stay, really.
I mean, regarding the coronaries, we didn't measure the functional testing of the lesions, but the LED lesion was clear for us to be really significant. Marginal as well, but it was a smaller vessel. But no doubt, if you think about surgery, coronaries have to be done as well.
So I will ask then Georg the other opinion. So as an interventional cardiologist, is it a patient that you think should be referred to you, and if so, why?
I mean, for the matter of discussion, of course. But first of all, I would also agree with Volkmar. For me, it's a classical candidate for minimal invasive surgical approach, and it's. I'm not a surgeon, but it's also an easy candidate from the mitral perspective. So it's one a beginner, not a beginner, but one of your collaborators, a younger collaborator could do. But on the other hand, of course, it is doable with a catheter-based approach. And if I would have to choose a catheter-based approach for this type of patient, I would think about an edge-to-edge device, certainly, because it's a prolapse. And I wouldn't think about a mitral valve replacement device in that case, because we have so wonderful treatment available catheter-based.
So I think obviously there is a lot of potential debate relative to the status of the patient. Obviously, being there in front of the patient and in front of this also environment around the patient is important. But what is clear is that it is an ideal surgical candidate, potentially, at least from an anatomical perspective. It is probably also an ideal transcatheter patient, and therefore, in my opinion, whatever the treatment is, we should be able to deliver the best possible treatment, which means no MR, no stenosis, whatever the approach is.
You know, one of the interesting points are also comorbidities in that situation, and your patient had chronic obstructive pulmonary disease. So do you have any, Francesco and Volkmar, do you have any cutoff where you say surgery is not the best option due to this particular comorbidity? That's something you don't look at so closely.
Well, if it depends a little bit. We haven't seen any values, so vital capacity or any other. So there are cutoffs, of course, where ventilation becomes an issue and where long-term ventilation, even tracheostomy, may come into play. So if a patient has severe pulmonary fibrosis, very restrictive, or COPD stage 4, that could be an argument for an interventional procedure, because end-stage pulmonary disease is certainly a risk factor for surgery. But, you know, sleep apnea doesn't fall in this category. I mean, this is a functional problem. It's not a pulmonary disease. So I don't think that this particular patient is at a very high risk for surgery. This is completely different from a patient with stage 4 cold disease.
Yeah, in this case, COPD was moderate, in the moderate range. The patient was using inhalers. And the problem with the sleep apnea usually goes with some chronic hypoventilation. That's something that anesthesiologists
and that will remain even after surgery. He needs to lose weight. I mean, that's
true, and he's obese as well.
Have that problem.
Unfortunately, he cannot lose the weight fast enough to get the best surgical procedure.
So we need to keep pace of the presentation, and you should show us how did you treat. And I think you are not a surgeon, so if you treated the patient,
but
should
maybe
be a
Francesco,
non-surgical
we
one.
can take a look at the answer of the audience.
Let's see the answer of
if
the
that's
audience.
possible.
Absolutely.
Okay, so the majority is for transcatheter mitral valve repair in that situation. But you see, the surgical part is still very important, I think, due to the excellent result you can provide. So what did you do?
So definitely it's a really balanced opinion that it's logical, but this is not a clear, straightforward candidate for transcatheter. So what we've done, so we discussed, of course, in our heart team, the patient is a 69-year-old male, was quite young. We calculated STAs for combined procedure with repair 5.8%, so it's in the moderate range. With replacements, 9.2%, a little bit higher risk. And we as well are using more and more this score. We developed the mitral score to understand the risk of the patient and the probability of the benefit with the transcatheter repair. And the patient has 2 points that is a low risk, so the probability is to good outcomes and good result. So after discussion the comorbidities, since the patient is not prohibited but has some comorbidities and probably is not the super optimal candidate, the decision of the heart team was to do a PCI to the LAD and mitral transcatheter edge-to-edge repair. Why we did this? Because we know that if in degenerative MR, and this is information coming from Everest, if we are successful, similar outcomes and less adverse events than surgery. We know that if we are successful, that's important, you have to be successful. And we know that in degenerative MR, MitraClip has provided long-term results with more than 80% at 5 years with MR 2+ or less. That this is important. So what we did in a stage procedure, we first treated LAD. This is stent implanted in the middle AD with absolute good result. We didn't touch the marginal branch. And then we, in a staged procedure, as I mentioned, we went for the mitral valve. So this is how we did the case. It was first clip was XT wide clip G4. You can observe we are checking the perpendicularity. We enter in the ventricle and we are capturing leaflets, as you want to observe, with the grippers down now. After dropping the grippers and closing the device, we see a little bit of extra movement as it was expected in the posterior leaflet. So we did optimization of the posterior leaflet, taking advantage of the independent gripper actuation of the G4 MitraClip. And this is the result we have. As you can observe, there's some small jet in the medial part, but we have extra movement of the prolapse segment still there. So if you want to be perfect and similar to surgery, you have to treat the color, and you have to treat as well the extra movement of the leaflet. So we implanted a second clip, XT, in the medial part of this prolapse, as you can observe by fluoro and by echo. We are pulling back really close to the prior clip, and we are going to drop the grippers now and close the device. This was a quite straightforward procedure, no major issues with that, and this is our result. A wonderful tissue bridge, no more prolapsing, and a minimal residual mitral regurgitation with a normal gradient far below 5 millimeters of mercury mean gradient. We have some follow-up of the patient. At 15 months, the patient is completely asymptomatic, no angina, no more heart failure, functional class 1, and this is the residual MR we observe. It's trace MR. It's almost kind of surgical result, and this is our case. So it's open for more discussion if you want.
Thank you. Thank you very much. Congratulations, Rodrigo. And the first question goes to Volkmar, obviously. So it looks like this is a surgical-like outcome in terms of MR reduction. I think trace MR is what we want to see also after surgery. We want to see no residual excessive motion. We want to see no stenosis. So I think that has been achieved. But obviously, what do you think about, this is a 15 months follow-up. We want to expect 10 years follow-up. What do you think?
Well, first of all, let me congratulate you to an excellent procedure. I mean, what we see is a good outcome. Treated coronary disease and a mitral insufficiency, and the outcome is good. And we have a follow-up that is unlikely to change for the next couple months or next years, because the failure rate that we see is typically early, not late. So if we have a stable result after 15 months, it's most likely to be sustainable. One thing I would like to discuss is your risk assessment up front, taking the STS data from combined mitral and CABG. I mean, this is 90% driven by functional MR and coronary, which patients in coronary artery disease usually have. So this is a very rare combination of primary MR and coronary artery disease. And I would submit to you that the risk is much lower than the STS score predicts in this case. But in any case, the outcome is good. And so I congratulate you for this result.
One issue, obviously, if you would operate this patient, now this patient got PCI. Now you have these options. One option is do PCI first and do minimally invasive mitral after a few months. You can do minimally invasive mitral and let the questionable lesion behind, or abandon the minimally invasive and go sternotomy. So what would be your choice?
Well, that depends also on the patient. I mean, if he would not object for sternotomy, I would put a Lima graft to the LAD, which obviously gives the most long-lasting result for the anterior wall revascularization-wise, and then repair the mitral valve. If he insisted on a small incision, then I would probably go ahead and do the PCI first, knowing that then we have to do the mitral valve probably under double platelet inhibition, but I don't think that is a major problem.
But just one remark: you could go only for 4 weeks of antiplatelets.
Yeah.
So
I mean, there's many ways to address that issue. It's not really a question, but I would rather have the LAD open.
Well, just one more question, because there is a lot of, and then we have also question from the audience. There's a lot of debate regarding, because when you repair surgically the valve, you will put an analoplasty as well. So
yes.
So you said probably if there is no early failure with the mitral clip, it will be stable. What is for you the value of an additional analoplasty surgically? Is that long-term result? Is that remodeling of the ventricle?
Well, we don't have any randomized control data comparing mitral valve repair with or without an annuloplasty ring. And it certainly remodels the mitral annulus, and if it's enlarged, I think an annuloplasty is a good thing to have. It guarantees long-lasting results, and it's the basis for our long-term data. So I would be rather reluctant to leave it out. If you catch a prolapse very early and there's no annular dilatation, you may argue that a ring is not needed.
Yeah.
But we see now with the clip what you called what did you say, a nice bridging?
Bridge of tissue.
Bridge of tissue, which as a matter of fact is massive fibrosis in a place where usually there's no connection between the leaflets. So I wouldn't call it nice. I say this is needed for the type of repair you do, but it's certainly not what the mitral valve looks like typically. So it's a fibrotic bridge, which is very stable after a while. So it also remodels the annulus to some degree, that we know, because it foreshortens the AP diameter. So the short answer is for standard mitral repair, I would still opt for an annuloplasty ring, in addition to the caudal repair of the
Which is also
mitral
non-physiologic. You block the ring in systole.
Yeah.
So let's be honest on both sides.
Yeah, I think surgery is also letting some degree of fibrosis, maybe not on the mitral valve.
But I think, honestly, again, I want to bring back the discussion, because we can discuss hours between surgeons and interventional cardiologists. What is fundamental here, we need to achieve the best result. I just want to ask you, I didn't, you used the XTW first, and the second was?
XT.
Now, I wanted to make a point about this, because I just reviewed the Expand G4 registry, which is telling, first of all, overall, in all comers, in a real-world situation, 63 sites around the globe, there is an overall reduction of MR of 0, maximum 1 plus, or less than 2 plus in 91% of patients, which is already an achievement compared to the past. And what is also very interesting is that the typical approach in DMR is to start with a XTW in most cases, more than 50% of cases, and the second and third clip usually is going to be an XT. The addition of the XT, just like in this case, the addition of an XT is increasing the rate of patients without MR, reaching in patients with 3 clips, reaching 100% of patients who are discharged without with a MR less than 2 plus. So once more, the message is, I think we are switching a little bit towards patients with a bit less risk profile, but remains one point that we need to achieve the best possible outcomes in these patients.
So Saib Alkar in the room is mentioning, and you see this on the screen, that this patient could have been randomized as well. I think that's a good option in the Repair MR study. There is one question regarding the gradient. So you mentioned that this is a surgical-like result, but maybe one of the difference in terms of result is the gradient in that patient with 5 millimeter of mercury. So Alison, do you think it's a concern in the long term for this patient?
I do actually, because I think this patient is fairly young. I think looking at the pre-procedural imaging, apart from the anatomy being suitable for surgical and edge-to-edge repair, there was also a very, very low, and we haven't mentioned it, a low risk of post-procedural SAM or peri-procedural SAM. So I think that post-surgical annuloplasty and repair, you would not be getting a gradient anywhere approaching 1 millimeter of mercury. So I think a mean of 4 in this gentleman possibly has long-term ramifications that he would not have if he had had a surgical intervention.
And another question here for you, Francesco or Volkmar. When you have the clip in, and the result is maybe not the best one, what is then the surgical management if this patient has to be sent to surgery? Do you replace or repair? What are the options there?
I think it depends about the timing when the patient is presented. So if it's an early failure, let's say you have a detachment or you have residual MR after 2 clips, and if you put 1 more, then you have a gradient, so you would stop the procedure. It would be great to send the patient to surgery immediately, because then we can easily retrieve the clips and still do a repair. If it's later, let's say a few months after the procedure, then it's more difficult to do a repair, and then most likely this patient, because of the severe fibrosis, will need a mitral replacement, which puts him at a different risk, as you have shown, and also changes his long-term prognosis. So the message here would be, if there is an early failure, to send the patient early, so then still a repair is possible and no damage has been done typically. So that would be something I would like to address in this audience.
Yeah, and that is probably very appropriate for this kind of patients, like this patient, where there is a debate whether surgery or interventional procedures should be done. In these patients, in my practice, I always tell the patient, we try. If it doesn't work, you need an operation within 1 month, or the same reason. And in some occasions, although I have to say we have been repairing valves also beyond 1 month, in those cases where the fibrosis is not too extended, and in those cases, usually I have been leaving the clip in place and I've been implanting a ring and fixing the residual lesion. So it can be done. Obviously, it's a matter of willingness of the patient, willingness of the operator, and probably we need to train the next generation surgeons to deal with complications of interventional procedures.
Just want to point out that this is a very important point, because when you speak to the patient, these patients that are borderline can be a perfect surgical candidate if surgeons are super top. You have to inform them like that, and the patient, you have to offer, we can do this. It's super minimal invasive. You go home next day, but it has to be a perfect result. If it's not, maybe you have to go to surgery. Do you accept this? And say, okay, let's try this. So
and
sometimes
you did so.
Always.
That you're a good boy.
And another aspect is
super nice boy.
Another aspect is in this type of patient that the interventionalist has to be more than 90% sure with the first clip on the hook, still on the hook, that this will be a perfect result.
Yeah.
Because then he could still bail out.
Yeah.
So if you would have seen with the first clip, okay, I can reduce it only by 50% or so after several approaches, I would highly recommend to get the whole system out and send him to surgery right away.
Okay, so it was already a good debate on a debatable case. Let's go to the next case. It's going to be presented by somebody. Is there anybody who's ready in the room? I think, Nicole, do you have a case? This was unprepared. Thank you. Bring the case. So Nicole Karam will present us another case which is not primary, correct?
No, it's not a primary, and but this is a case I wanted to share with you. This is one of the most memorable cases I've had. If I only manage to get to my slides. So we are in 2015, so 7 years ago. This is a 39-year-old male with 2 young kids, and he was referred to us by what will become later the heart failure unit, but they were already doing the job of a heart failure unit. And they sent the patient with the following history. So dilated cardiomyopathy, for which he was followed since 2006. He had an ICD as a primary prevention, but he didn't need a CRT. He had narrow QRS complex. He was relatively stable till 2014, and in 2014 he started having recurrent hospital admissions for acute heart failure. And the patient was, at the end, just lying down, spending the day at home, not working, NYHA 3 to 4. The treatment is the treatment that we could have had in 2015, so it was as optimal as it could get, but it was ramipril, some ARBs, some beta blocker, spironolactone, furosemide. I mean, this is not what we have today, but this is first the optimal doses he could get because of his blood pressure, but it's also what we had in 2015. So again, no need for CRT, and the group was trying to offer him a cardiac transplantation, but the patient was not ready for this idea. He was not willing to accept the heart, I cite him, the heart of another person in his heart, in his chest. So they came to us saying, look at what we have. And if they look at the history of the patient, the big difference that had appeared during this time period is the development of a mitral regurgitation. And when the patient was sent, I mean, again, we are before MITRA-FR and COAPT and all of this. We have a patient with a 20% ejection fraction, a dilated left ventricle, dilated right, with an EROA of 0.24 square centimeters. Not too high, but I mean, we know the limitations of EROA. Vena contracta of 6, TR grade of 2, and the right ventricle has a TAPSE of 13, and the SPAP is 44 millimeter of mercury. So how would you treat this patient? Should we still insist on transplant, LVAD, or mitral repair, which was the reason why he was sent to me?
So please vote.
So we have to wait voting. In the meanwhile, just one comment is a typical mitral-FR case. So no much MR, large ventricle, low AF. So it's non-coapt for sure. Let's start from here. And the other point is about transplantation. I want to, Volkmar, you have one of the largest heart transplantation units in Europe. So what happens when these patients refuse cardiac transplantation? Is it happens sometimes. The patient do not want to get into LVADs or transplant.
Well, this is clearly a complex discussion now that we're starting. First of all, we have not enough information to even know if he qualifies for transplant. I mean, there's certain other criteria that needs to be fulfilled, and psychological assessment is one of them. And if the patient refuses, I mean, that's the end of the story. Now, the other question is, would he qualify for a left ventricular assist device? And he's a classic frequent flyer, Intermax level 3, so frequent hospitalizations. And he would classically qualify for a left ventricular assist device. Right ventricular function is still okay, so it's the right timing, which in this age, of course, can only be reviewed as a bridge to transplant. So if the patient refuses transplant, the question is, why would he accept an LVAD? And that would put us in the situation where LVAD would be destination therapy. And even under the light of the latest HeartMate 3 results, which are quite good, with good 5-year outcomes in this young population, there's also a lifelong risk of complications with an LVAD. So, yeah, it's also a question who talked to the patient, and we would definitely bring him in front of our transplant and LVAD team and have also a peer patient with an LVAD discuss the option. And that sometimes changes the mind of the individual, because after all, the quality of life can be good. But there's restrictions if you have 2 small kids. I mean, so there's a number of factors that come into play.
Yeah, it's a very important outlook on the discussion. I mean, again.
One more point is, of course, we don't have transplant available. I mean, even if he would consent in Germany, and he would qualify only for elective transplant, so he would put on the elective waiting list, and that means 2.5 years of waiting if you're unlucky. So in between, anything can happen, and so that's also part of the reality. In Spain, he would get a heart within 4 weeks. So it depends largely on what country he lives in, also if it is an option that you can really offer soon or later.
There has been a recent publication on patients in the waiting list for transplantation undergoing mitral procedures, which shows some benefit in some of these cases of being delisted from transplantation. It's not a contraindication for transplant, obviously. What about LVADs? Do you think a patient who got mitral could be a bad candidate for LVAD? Sometimes we hear this coming from.
It absolutely does not matter.
Exactly.
I mean, unless you create severe mitral stenosis with 3 or 4 clips, because then the inflow is restricted.
Absolutely.
But if that is not the case, a clip doesn't matter at all.
So, and I ask maybe you, Fabien, or Georg, Roy, Felix, whoever wants to answer. So this is today a patient probably, would you still consider a patient like this? I mean, he's a mitral FR patient. And not much MR. What do you?
If the morphology is okay, and that means that I'm not creating stenosis, the chances are high that I reduce MR to mild or less. And the patient is against the wall with his back, I would definitely consider TEER as just one of the heart failure treatment options there's left before heart transplant or LVAD comes into place.
Yeah, for me, it would be a very clear decision. That is, I think, a classical TEER candidate, because harm is very, very infrequent. So it's going to be a very safe procedure, and it's not a preclusion of any other therapy in that patient. So why not doing this? And if you look at this non-coap patients, they also benefit clinical-wise in terms of exercise capacity, quality of life. They benefit as much as a co-op patients do, the classical co-op patients.
And maybe
therefore this would be not an exclusion.
Maybe they've been prior to non-co-op, they were co-opt patients, so they refer to late.
And there's this other paper coming from mitral FR published in Intervention that in the long term it looks like rehospitalization still decrease in those patients.
Exactly.
And the other point is you don't have too much MR, but we have to acknowledge that this is a dynamic process. Maybe in some other point it was torrential MR sometimes. So I think it's a very good candidate.
So basically we agreed to treat these patients, and
let's look at the result.
Exactly. I suppose that you have the...
But maybe the result of the poll first.
The results of the poll, sorry. Yeah, that's interesting.
It's still split. Huh?
There is half of the audience who wants to convince the patient that transplantation or LVAD is better.
I think your strategy, a lot of people are advocating this to try to convince the patient or speak more with the patient in the overall situation to convince him or get a way to transplantation. But in the guideline we have a 2B recommendation for this non-co-op patient, so I think the third option is also a good one. So what did you do?
So it's very amusing to be discussing this case with our 2022 eyes, because if I remember 2015, we were more asking ourselves if we have the right to close a mitral regurgitation, and maybe it's helping the muscle to get some relief by pumping to the left atrium. So our discussions were much more basic than what we have today. But back then, what we decided is to try to do a mitral tear procedure and give him more time to get used to the idea of transplant and maybe to meet other people with LVAD or whatever, but try to bring her to something else, and the idea was just to perform temporarily a tear procedure. So I'm sorry for the quality of the images. It's 2015, and this is what I could get. So basically, it was a simple case of A2P2 mitral regurgitation with no calcification. And so this is the clip. Oh, okay. So this is the clip that we implanted in A2P2. We needed 2 clips for this case, but it was a Gen 1. So again, no discussion for the choice of clip. That's the only clip available, no different sizes, and we had the 2 clips implanted. And 1 month later, the guy came back, and this time he came with his boy, who was an 11 years old, and the boy was there to say, "Thank you, my dad is back." And it was the first time he was going out of home with his daddy, and he wanted to just tell us thank you for bringing his daddy back. And this is 3 months later. We see that we have some residual MR, but I mean, we were able to increase the dosages of beta blockers. Now we had bisoprolol 7.5. We increased the spironolactone dosage. And if we see at what happened, because the patient has never had a transplant after all, so if you see how things went with his LV ejection fraction, so we had the 29%. We had a point in 2019 where we had the 35% ejection fraction. What also changed in the meantime is that we had the introduction of new medical treatment for heart failure, and we could put those treatments now that the blood pressure could allow it. And now we see that we have some decrease in LV ejection fraction in this patient again. The TR grade was reduced from 2 to 1 with time. Right ventricle was doing very well, and we had an improvement in TAPSE. And we see that the SPAP did decrease initially. Now it's increasing, so we're keeping an eye on that. And just to give you the final follow-up, which was 7 years now, this was in August. So we had the 7-month follow-up. And as you can see, we still have some mitral regurgitation, this residual MR that we had right from the beginning. But the patient is still there, and he has an ejection fraction of 20%. So basically, we are very close to the baseline, but the difference is that the patient is much less symptomatic now. The left ventricle did not dilate this much in the meantime. TR grade, we changed our classification. It's still a 2, but now it's a 2/6. And now we have all the other treatments of heart failure that were introduced. Thank you. So what I wanted to share in this case is the stability of the results, because back then it was supposed to be just a temporary solution to get to the transplant, and this is something that we've seen also with Metrobridge registry, that some of the patients finally get out of transplant. But what is impressive is also that those results could be stabilized with the 7 years. But we also have to remember that we need to keep improving the treatment, and the patient is still a heart failure patient. But the mitral regurgitation could be treated efficaciously and on a long term. Thank you.
Very nice, Nicole. Thanks a lot. I think my take-home message also from the discussion we had before, we still have to do a lot for these patients. The disease is anyhow progressive. And there is no way out on this discussion if we don't get more to work together. All the professionals should be involved around these patients, electrophysiologists, heart failure specialists, and so on. And I think actually what you demonstrated in this case is that treating MR in end-stage heart failure patients may increase the compliance to heart failure therapy. Actually, over time, you've been able to introduce the newest therapies, which sometimes are not tolerated by patients with severe MR. So I think that is a change in perspective, and also puts this procedure in another ballpark as compared to LVAD and transplantation. I mean, here we're talking about more or less, in my opinion, a mitral clip being a safe procedure should be put a little bit closer to drug therapy than to device therapy, in the meaning that you are dealing with volume overload treatment. But again, this has to be still developed, because at the end of the day, we see some problems still in understanding who are the best candidates. And we always say we see patients too late, but at the end, these patients come in late. So, Alison.
I just wanted to make a point. I think we didn't get a chance to discuss the imaging on this patient before we came to the conclusion. The few points that I wanted to make, and they might be controversial, but certainly the ventricle was dilated, as we could see, and the end systolic dimension was over 6. So this was already predicting independent left ventricular systolic disease, which we knew that ventricle was not going to come back down to normal size, number one. Number two, that the study was performed with a heart rate of 55. We didn't know what the blood pressure was. And definitely these patients can have dynamic mitral regurgitation. Number three, we could see that the mitral valve leaflets were pointing into the left ventricle, definitely due to left ventricular remodeling. But the tenting height was not that high. It was not more than 2.5. So although the repair in this patient might not have been perfect, it certainly wasn't the worst remodeled left ventricle that we'd ever seen. Number 4, I think that the right ventricular impairment was there. It wasn't awful, but it was there, and the patient had pulmonary hypertension. But I think the single most important thing was that you measured the EROA on 2D imaging. And this will give you a one-dimensional view of something that's three-dimensional. And that's why you get an EROA of 0.24, which is completely underestimating the severity of this person's mitral regurgitation, even at a heart rate of 55. So I disagree. I think this patient is a perfect case for mitral valve edge-to-edge repair because the patient had severe mitral regurgitation.
Excellent. I think that is an ongoing discussion. There are different opinions also in the audience, correct?
Yes, so we have comments. You see them as well. So Saibal Kar, I don't know if you want to take the mic to.
Where is Saibal?
He's hiding.
But he was arguing, you see, that, and that's maybe some comment for Volkmar as well, that thinking of cardiac transplantation in a 34-year-old patient is maybe not the ideal therapy. Is he?
Hey, can you repeat what you wrote?
Yeah, I actually, sorry, I was a little bit more rude than that. I just said offering a patient a heart transplant in a 34-year-old patient who's reluctant to have a transplant is heartless. And that's what I said. And I have and since you remember in the co-op trial, we had patients, as you can see in the co-op trial, that we deferred or delayed heart transplantation significantly in the patients who actually underwent MitraClip. So there is nothing wrong about offering a MitraClip in this patient, in a 34-year-old guy, even if you delay the heart transplant by a few years, because we do know that heart transplantation of LVAD has a finite period. And so even if you delayed by 5 years, it is the right thing to do. So those people who offered LVAD and transplant a 34-year-old guy, which could be fixed by a MitraClip, and as Alison mentioned correctly, that in this case, they had underestimated the severity of MR by just ERO. And in the co-op trial, we did not only use ERO. This patient would be perfectly in the co-op trial. It's a perfect candidate. That we use a multi-parametric analysis. That means we use E-wave, pulmonary reversal, regurgitation volume and fraction to decide whether the patient is severe MR. And you rightly said, this patient had severe functional MR in a patient with heart failure. So this is the right treatment. So this is a co-apt patient.
Maybe, Saibal, one last question. Volkmar, do you want to react? Sorry.
Yeah, no, I agree that, I mean, the result was good. What I found very interesting is the time course after the mitral clip. So we saw a reverse remodeling for some time and then remodeling again, but pulmonary pressures went up, right ventricular function went down, and also left ventricular systolic dimension increasing. Now let's assume at this stage that the newer heart failure medication wouldn't have again led to a reverse remodeling, which we saw, luckily. then this would be the time point where you had to really discuss with the patient LVAD, because an LVAD is good if the right ventricle is still functioning. If you wait later than that and the right ventricle starts deteriorating, if the pulmonary pressure eventually goes down again and autopsy is less, and so that is then really a problem. So the sweet spot for LVAD is before the right ventricle goes down. So that's one important message I think we should convey. If heart failure medication leads to reverse remodeling, fine. I mean, then we can wait. And finally, transplant, if you can delay transplant, is a good thing, because immunosuppressive therapy also has its problems. I agree.
In this patient, actually, the TAPSE improved, correct? So the RV, Dr. Wachman, the RV function actually improved over time. I rightly agree with you that we should select the patient. If you give him 5-6 years of time, you can still talk to him about transplant and LVAD and convince him, rather than pushing him right to LVAD and transplant from day one, especially when he's reluctant. So I think you did the right and compassionate and human thing for the patient.
Thank you, Saibal, for bringing some humanity to the podium. And so now we move to the next case, which is going to be shown by Monish Shuvi. Is a case, if I understand, where there is not much time for thinking.
Yes, right. There's no time for thinking. See. So let's start with the case. So this is the case of acute mitral regurgitation. And this is my disclosures. Let's start. 72-year-old woman, hypertension, dyslipidemia, and current smoker. Presented with chest pain and dyspnea. She felt very badly for a few days, but stayed at home. And she was admitted with late arrival chest pain, late arrival acute inferior ST elevation MI. You can see here in the EKG, ST elevation MI in the inferior wall. She was in KILIP class 4 in cardiogenic shock. You can see the chest X-ray showing diffuse pulmonary edema. On the cath, you can see here the cath. You can see an occluded left circumflex that was not really opened successfully, and she ended with non-reperfused late arrival inferior ST elevation MI. And we can see here the echocardiogram showing moderately reduced LV dysfunction, mostly due to akinesis of the inferior posterior wall. And we can see the tethering of the leaflets causing severe mitral regurgitation. Importantly, there was no rupture, there was no papillary muscle rupture or any other damage to the valve. All the MR was related to the posterior wall infarct. So what are the options now? Patients in cardiogenic shock, what would you offer her? Medical therapy plus minus Impella, ECMO, or some other support device, surgical mitral valve replacement in a relatively young and healthy woman, or go for a mitral clip procedure.
So I think you can vote again on these three options. Yes, so the voting is open.
So when you say medical therapy, you include obviously also mechanical support eventually. So the concept is try to support the acute myocardial infarction without any structural treatment, or address the situation. So Georgi, we start from you. In your practice, what is your, first of all, you see this patient, so.
Yeah, I mean, it's an unstable patient, obviously in shock, so he needs treatment, and he won't get along just with medical treatment, I suppose. So he needs more than this. He needs maybe two things: revascularization. That's what we have to discuss, and then of course to fix his mitral valve. So I'm not sure whether it was tried to do a redo on the circumflex artery interventional wise. This would have been my first option. And if the patient is unstable, once he is presented to the hospital, I would support him definitely also mechanically. If he, we would have to have more information on the respirator situation, on the catecholamines and everything. So, but he would be also a candidate for a transient impeller, for example. And then we would have to decide in the heart team on the mitral valve. So if you are able to revascularize the circumflex artery interventionally, this would be an ideal, I think, a good candidate then for a rescue mitral clip procedure in that setting. The other option, of course, is doing surgery and fixing the circumflex artery and also fixing the mitral valve. But we know that the outcome is poor. We always have surgeons who can do this, but the mortality rate of that procedure is extremely high.
So, Georg, why don't we ask Rodrigo, because Rodrigo has been collecting data on this.
This is we work with Moni and with Maurizio Taramasso, working in this type of patients. We identified, there are two mechanisms to arrive to this acute mitral regurgitation ischemic. One is, of course, the rupture of the papillary muscle. That is a terribly emergent situation, but we have almost 50% of cases with this kind of functional etiology that is created by the local remodeling of the LV dysfunction. In those patients, we have collected a series published in European Heart Journal. Compared to surgical interventions, prognosis is a little bit better with the mitral valve repair. Of course, retrospective.
There is one limitation to this paper, and it's the time between the event and the treatment.
That's it.
And the time between the event and the treatment is much shorter in the surgical patients, much longer in the patients who have been treated with mitral for many reasons.
Yeah.
And that is probably an important confounder. Obviously, it's clear that the safety profile of mitral clip has no comparison with surgeries. These are two totally different situations. So probably, but the question is the timing, in my opinion, in this paper, because okay, it's not a papillary muscle rupture.
Yeah.
There is no time. Here, there might be some reversibility, and there might be some time for taking the right decision.
What we have seen is when you develop this kind of remodeling, even if you treat the circumflex, this MR will stay there. And it's the responsible for the clinical situation of the patient. It's not the LV dysfunction. So the earlier you treat it, the earlier the patient recovers. And so the sickest the patient, the less invasive we have to be in the approach. This is an essential case for mitral clip.
I just wonder, could we just pick up the imaging on the screen again? So there's a couple of points just to bring up, and they are really important, and we are trying to teach. So really, not that one. Go back.
Sorry,
Don't give the game away. Go back.
Let's see.
Okay, if you can't, don't worry. I think we're...
Yeah, can we go back to the slides?
We're going
because
the wrong way.
You are showing us all the slides.
Just showing the whole session.
It's not really...
But Georg, I think it's very interesting. Your first target would be the circumflex, and to try it again.
Go back one more, Felix.
I mean, I don't want to interrupt.
It's just, first of all, the first point is this ventricle is not moderately impaired. This ventricle is very significantly impaired. And the reason I say that is look at the way that the mitral annulus is not moving up at all. So there's no longitudinal function at all. The second thing is look how fast the heart rate is. The heart rate is probably under vasopressors, is on inotropes, it's got some mechanical support. The one thing you must not do, because all the blood volume is going into the left atrium and hardly any of it is coming out into the aorta, so the person is only surviving with a cardiac output because of the heart rate. So you must not slow the heart rate down in this patient. This patient is in intensive care on a knife edge because of significant physiological hemodynamic disturbance. I think the treatment is urgent, and look at the jet of mitral regurgitation. Yes, it's very broad, but we jumped in too early, forgive me, for saying that this patient is a suitable candidate for mitral clip or edge-to-edge. He might be, but we cannot tell that on this image. We need much more information to be able to say with clarity that this patient's got a definitive transcatheter option.
So let's see what the audience have been suggesting us. Can we see the slides? So most in the audience obviously supports transcatheter mitral valve repair. I think there is a bit of bias in this community, but it's fine. I think, but I think honestly it is a good option. Let's see what you did, Moni.
So it's very interesting, the results of the poll, because when I presented the first case in 2017 or 16, all the surgeons said it is unethical to do such a procedure because there's no data about it, and some of them even referred it as a sham procedure. So I think that we are getting more and more data that is really doable. I think it's working by itself here. So let's go to the next slide. So this patient had underwent a mitral clip procedure because he was considered as a very high risk for surgery. And of course, medical therapy is not really relevant in those patients because they're hypotensive. You cannot give them afteral reduction. You cannot give them any medications that really can harm the kidney because they have acute kidney injury. And therefore, all the medical therapy of this condition is unfortunately irrelevant. And this patient underwent an urgent mitral clip procedure. We can see here the result of the procedure. You can see the immediate improvement in the hemodynamic parameters. The minute you close the clip, the VWAV dropped from about 50 to around 15. And you can see in the cath lab that the blood pressure goes up immediately when you close the clip. And you can see here in the end the reversal of the left upper pulmonic vein flow before the clip and immediately after closing the clip. And therefore the clip in this patient scenario is really effective in hemodynamic parameters. So we published our data, me and my friend Roy, in 2019 in two registries, and then we combined the registries and added some more patients and compared conservative therapy versus surgical and percutaneous treatment for acute mitral regurgitation among patients after myocardial infarction. And we were able to show that the worst thing is to wait and see. Patients with conservative treatment had the worst outcome, almost 40% mortality during hospitalization. Intervention was associated with better outcomes. And when comparing surgical intervention to a mitral clip procedure, both are very successful in decreasing the MR, more than 90% success rate in both methods. However, high complication rates among patients who had surgery, 30% complication rates led to less survival compared to a mitral clip procedure, and therefore the outcomes for the mitral clip procedure, both in hospital mortality and in 1 year mortality, were better than surgery. So this is a follow-up of this patient. First, the mitral clip allowed the recovery of the patient. 2 days after the procedure, the patient was extubated, and a few days later, he was discharged from hospital, which means that the clip was a bridge to survival among those patients. And we can see here 2 years follow-up, patient is doing well, near class 2 on medical therapies that could be initiated due to the important hemodynamic improvement of the clip. And he was in near class 4 on medical therapy. This was the patient.
So Moni,
thank you very much.
Excellent presentation, and really very happy end, I would say, in this particular case. I want to ask you 2 questions. So number one, how long, when did you do this? So the patient presented, how many hours or days after you treated this patient?
So this is a very important question. What is the best timing of those patients? So in general, patients that are decompensated, which means in pulmonary edema or cardiogenic shock, and you cannot really treat them by medical therapy, should go for an urgent procedure. Last week, we decided to do the procedure at 3 p.m., and in 6 p.m., the patient was after mitral clip. So we were able also to provide an immediate response to those patients. In general, in patient cardiogenic shock, if you can do something, do it early. And if you can afford them a safe procedure immediately, I would go and do it.
Yeah, because that opens one big issue, which is availability of this therapy. I mean, this is not like PCI. You do primary PCI at any time in the day. I don't think if there is any hospital who is able to deliver out of the box this procedure. I mean, if the patient comes in the morning, obviously yes, but if he comes after 6 p.m., I don't know if any of you can do emergency mitral clip. Is
Next
anyone?
day. Next day.
Next day.
Yeah, but this should be sufficient as well. I mean, we
Sure.
should not exaggerate. It
No,
doesn't
I
have
agree
to
with
be
you.
in the next hour. So you have other measures to do. And another point is you need always more information in this patient. Usually this is a patient with high inflammatory markers, with sepsis. You need to know the hemodynamics. Is it only cardiogenic shock, or is it a mixture of inflammatory disease, SIRS, and so on? Because usually these patients have a multiple arrays of additional problems, clinical problems.
So it depends. The post-MI patients, the young patients, mostly it's cardiogenic shock. And you can also evaluate it by hemodynamic evaluation. If you see a V wave of 60, you don't have much of differential diagnosis. It's important that sometimes there is underestimation of the severity of the MR by echo in these acute conditions. Like we sometimes do not hear the murmur because there is equalization of the pressures. Sometimes the color is not very impressive, and therefore there is a high need for suspicion. If you have a patient that is cardiogenic shock out of proportion of his LV or other condition, you should consider that he has severe symptomatic mitral regurgitation.
Is there any fear in these patients to determine afterthought mismatch?
That's always there. That's always there because, as Alison pointed out, left ventricular function is much less than that we see. It's hyperdynamic because volume overload. Sometimes you close that, you can go into a bad situation, but you have to support that.
I think it's my understanding that when you put the clips in, or the devices in, there is time a bit. It's very rare now to have complete left ventricular failure during deployment of the first device. But certainly for sure, in the first post-procedural transesophageal echo you showed, the LV was hardly moving. But, this patient was presumably on intensive care and had been, swamped in inotropic, support.
Right.
But post-procedure in the transthoracic, obviously then the ventricle had time to regenerate. Its steam and was ejecting into the outflow rather than anywhere else. So, but definitely it's not like some of the other devices where, it's like turning the light bulb on and you have completely different hemodynamics within a few seconds. It's not really like that.
I think that what is really important is the increase of the cardiac output at the end. And that's not necessarily related to the function of the left ventricle, because you just diminish the flow of the mitral regurgitation and can have a good effect on cardiac output, even if you have a mismatch.
Falcon?
Yeah, talking about cardiogenic shock, I mean, we didn't have any lab values, lactate levels or anything, so that would be important in assessing how severe cardiogenic shock is in this patient. And I think one important message is also that unloading with a small impeller is not enough in these patients. If it's really cardiogenic shock, 2.5 liters of additional output is not enough to rescue the patient. So our strategy these days, if you can't intervene or you don't want to because the patient is in severe end organ failure and you first want to stabilize end organ function, then we would opt for an impeller, ECMO, and a large impeller, 5 liter, through an axillary access. And that allows for safe unloading, provides supernormal cardiac outputs and organ recovery, and buys you time for decision making. And then we would wean the ECMO first, and then leave the impeller, and then slowly wean and eventually intervene, whatever it is.
Yeah.
Okay, I think that brings again the importance of the complexity of these cases and the different approaches, and obviously having more tools in your portfolio is always an important point. Thank you, Moni, and we have to move to the last round. The applause is because you won the round. I don't know, maybe. Now, Anna Sonia Petronio will discuss with us another case, which is a difficult case, complex case. We need to give you, it's there. It's there, the clicker. We have a anatomical complexity here.
See if I'm able to see my conflicts. So I'll show you a case of a patient of 77 years old. She was a lady that came to our attention in third year class, atrial fibrillation. She was referred from another hospital. She had a history of coronary artery disease. They controlled their coronary angio, but there was nothing of important. She had a moderate COPD. And in her history, in 2005, she had a replacement of the aortic valve with a biological prosthesis Paramount 25. These are the echo parameters, the transthoracic and trans-echo. You can see here the ejection fraction is 50%. We have a mitral area of 4 and regurgitation volume of 64. And there is a described tethering of the leaflets. And here are the imaging of the patient. You can see there are multiple jets. It is quite evident that the posterior leaflets, it's very short. And remember that the patient had an area of 4 and a gradient. Here is the complete 3D echo 2. And you see that the shortness of the posterior leaflets is 6 millimeters. And we find 5 millimeters of gradient gradient between the atrium and the ventricle. So, what option should we give to this patient? Has 2 valves. 1.6. The aortic valve had a moderate degeneration of the valve, calculated with 29 millimeters of mercury and an AR of calculated as moderated. So the options are a redo, surgery for both valves, a TAVI with a mitral repair, or a TAVI with a mitral replacement.
Thank you.
So you can vote.
That's the chance to vote.
Everybody can vote. 2 transcatheter option, 1 surgical one, complex patient with combined disease.
She said moderate deterioration. I haven't seen a gradient.
Volkmar, it's a clear cut for you. It's.
Well, I wasn't quite sure, but I may have missed it. What was the problem with the aortic valve? Moderate AR or AS or what?
Both.
Both.
It was 29 of gradient and moderate AR.
29 gradient,
mean gradient
and moderate. So requires the aorta.
If you want to see back the images, it had a thickness of both.
So it's a rheumatic patient, correct?
2 valves.
Yeah, so in that case, the problem here is, I already know that this will not be a surgical case, right?
No, you never know. You don't know. You don't
Such
know.
a poor guy.
Maybe it is.
Maybe not.
But in any case, she has a clear indication to do something. The problem here is redo aortic valve could be done. And probably repair is difficult given the moderate stenotic component, so it would end up in a double valve replacement, I think. Although it would be tempting to just do an annuloplasty. On first sight, we were just discussing, it looks like a type 1 problem with an enlarged annulus of the mitral valve. But then there's already some degree of stenosis and a mitral valve area of 1.8 or what? 1.6. So probably it would be more safe to do replacement.
It is a rheumatic case. I mean, if you look, there was a pseudo prolapse of the anterior leaf. The jet was a bit towards posterior, and the posterior leaf is thickened. So basically, if you treat this patient, there should be a replacement. So one option would be double replacement, which carries some risk, let's say. We can discuss that. And the other options are here.
So just a couple of points just to add to the imaging. So the LV did not look particularly large. There was some concentric left ventricular hypertrophy, presumably going along with her previous and current aortic valve disease. So that's important because, you know, at first sight, it does not look like an easy case for a leaflet repair. Insofar as the posterior leaflet was short, it was only 6 millimeters, although not particularly restricted, but it was short. Really, you're looking for something more than 7 millimeters. And the other thing, of course, the area was very small, 1.6, so putting any device in for a repair device is very likely to make that area smaller and increase the gradient. So that's why then you're potentially thinking, if the patient is not clinically or anatomically surgical, do they have the anatomical features that would render them suitable for transcatheter mitral valve replacement? And that's why the next question in my mind is, how big is the left ventricle? How big is the LVOT, and what is the annular sizes? Because these are the first things that you need to screen out or in if you're thinking about transcatheter mitral valve replacement.
So, Alison, I think what is very clear and need to be recognized, and you highlight very nicely, that this anatomy is not suitable for transcatheter edge-to-edge repair. I think that's quite clear because you have gradient already, so you will not be able to have a good result in that patient. But now there's a lot to discuss, and because we need to address the aortic valve as well, and that's a valve-in-valve procedure if we go for a transcatheter option. So what would you propose to do in that situation in terms of timing, in terms of concomitant or separated procedure? What would be your approach?
I mean, the aortic valve is still moderate, so I would start. I think the mitral valve makes this patient symptomatic, so I would definitely start to work on the mitral valve and do this pre-procedural evaluations. We need to know whether we can place a mitral valve interventionally there, and most important issue here is size, anatomy, and LVOT. If you think, for example, of a transapical approach, it's certainly not a edge-to-edge candidate. No, 100% not a candidate. If you have a mitral valve orifice below 3 centimeters, don't even think about this. So it's going to end up with a gradient. So, and the other option would be, of course, do surgery, but it's 78 or 79.
It's a redo, yeah.
And it's a redo procedure. So I would tend to do that interventionally.
But that's very interesting. So you would go mitral first and then see what happened with the aortic. Felix?
Honestly, I didn't really pick up how sick the aortic valve is. But
it's a combined disease, so you know the aortic valve is gone.
The valve is 30 mean gradient and moderate
in a patient with mitral regurgitation. So that would probably be a good argument to treat aortic disease first. Would be my bet, to make sure the reduce afterload first by replacing the aortic valve.
But it's a degenerative mitral disease. You're not going to change the mitral valve by replacing the aortic valve.
But any risk, Georg, you think of going for the mitral without treating the aortic in terms of hemodynamic outcome?
Yeah,
during the procedure?
What you hear is that if you do the mitral and then the aortic stenosis will be more severe, but this is only a measurement. The measurement will be higher. That doesn't mean anything. You know, you increase cardiac output, you get more measurements, but symptomatically it's already one step forward. And probably it will end up in double replacement.
And you can run into issues during the procedure. Let's assume you predicted an LVOT of 280. I'm just making up a number, and then it's bad, it's worse. So you have an LVOT gradient, so you have to rethink surgery, and then you have done the TAVI already.
Okay, that's a good
point. The valve and valve. So I would definitely.
That's a good argument. Felix, I was more on your side, so probably we will go for the aortic first and then the mitral. You go for the leading one, which is also an interesting option. And Alison, you want to...
Just want to, because I think point Francesco, you just made it, but obviously we might be underestimating the pressure drop across the aortic valve in the presence of significant mitral regurgitation. That's, we haven't got all the information, but it's my experience that if you've got aortic valve disease, mitral valve disease, and the aortic valve is significant, certainly you should deal with the aortic valve before the mitral valve. But definitely, just a word to the wise, since we're educating, is if the aortic valve disease is regurgitation, you will need to rescreen the patient because the LV size will likely change and the LVOT dimension will likely change. You will probably get away with it if it's aortic stenosis.
Okay, so again, complex case. We need to see what the audience decided for us. Okay, TAVI plus TMVR is the leading suggestion.
But that's interesting, Francesco. There is 1/4 of people suggesting still to do transcatheter edge-to-edge repair. I think that's not doable. Everybody agree on this?
So can I just clarify this? Valve area is probably one driver not to do mitral clip in this patient, but the most important driver, it is a rheumatic patient. Please do not use transcatheter edge-to-edge in rheumatic patients. You will create stenosis. Full stop. There is no discussion around that. The problem is not only the valve area, it's also the pliability of the leaflets. So this is not a candidate for transcatheter edge-to-edge repair. Unless you have specific reasons, like let's say there is a flayed in a commissure, so you can probably close the commissure. But if you put the clip in the middle, which is what you should do, is a broad jet, let's say you try, you will get a tremendous gradient. So please, those 25%, I don't know how many you are, but come to me after we discuss more. So
okay.
Sonia.
Okay, then I'll show what we have decided. First of all, we wanted to see if there was another option, because we agreed that we didn't want to do TR anyway. And the patient was beginning with a 5 of gradient and a short posterior leaflet. So we took the we did the CT, and here you see the measurement, and we saw that it could fit 33 tendine valve for a replacement, here with a 15% oversizing. And again, there was a good option to have a good now LVOT, even if the ventricle was not so dysfunctioning, and it had 400 of space of the area in systole, and these are the imaging in diastole. You can see even that the access of the for the valve was quite easy, was close to the apex, was not a lot posterior. So sure that we could have a replacement for this patient. Then we decided that we first would put a valve in valve, and we decided to use an Evolute Pro 26 on this Perimount 25, and this is the result. Then after a few weeks, then we looked the echo of the patient. The patient always had a multiple jet. The parameters didn't change a lot. You can see here that the regurgitation of the aorta isn't anymore there. You can see the valve. And so we decided to replace the valve, and this is the imaging of the deployment. And you can see that even if there is a valve in the aortic place, there is a good positioning of the tendine in the anterior side. Here again is the other last imaging. There is no paravalvular leak, and we changed from 5 millimeters of mercury to 1, and 5 millimeters of gradient of the aortic valve. So the patient resolved both. This patient was treated in spring this year really, and I think I can show you the 6 months follow-up, and the patient, it's fine. Thank you.
Thank you very much. So my first very quick reaction. So I've been thinking about all these options we had, treat the mitral first, the aortic first, and you follow the aortic first, which I think is usually the right way to go. You go for the afterload first, and then you go for the rest. But there is one question now. Now you don't have any aortic stenosis anymore. There is no AI anymore. Don't you think it would be safer to redo CT scan in this patient, or let's wait for some months to see if there is a reverse remodeling? That is one question I have, because obviously the hemodynamic changes may affect also the shape of the ventricle.
I can tell you we waited a few weeks because we wanted to check this option. But in Italian you say you see the spring from the morning. And it looked like really the regurgitation didn't change a lot. So we decided to go for the valve.
Yeah, the only challenge obviously is if the ventricle remodels for any reason, then it might become a problem of LVOT obstruction. That was the only question. But anyhow.
Two aspects. This is a staged procedure, so you did it in two different procedures, and the second one is a surgical. I mean, you mentioned that the patient will not be treated surgically, but actually he was in some way, because tendine is also, or part of it is a surgical procedure. Volkmar, what is your reaction to that? That's complex patient, two procedure. I'm sure you will say you can do it best in one.
Well, I think it's one of the biggest advantages of transcatheter techniques that you can actually separate the procedures, because often in multivalve disease we see reverse remodeling happening, we see a decrease in the amount of MR after an aortic valve replacement. All these things can be addressed with caution and with a period that is long enough to know if the hemodynamics change or not. And that is completely different in surgery, where you, of course, would never do a restenotomy 6 months later and wait and decide then. So basically, if you do multivalvular disease surgically, it's a one-stop shot. And that leads sometimes also decision-making that is difficult, because if you have a moderate aortic stenosis in a patient with coronary disease, I mean, we tended to treat this. Now, there's no indication to do this, really, in the guidelines. So to separate procedures and really wait for hemodynamic changes to come is an advantage of transcatheter therapies.
And listen, is there a way to do the same procedure in one step?
Absolutely, there is. I think Leonard has done a TAVI and a TMVR in a patient in October, and last week we did an Edwards TAVI with a TMVR in a patient with MAC in the same procedure.
Yeah, the only challenge is the cost of the procedure.
Absolutely, absolutely. It can be prohibitive, and certainly in some countries it is prohibitive.
But, and on the other hand, again, I think you are spoiling the opportunity of understanding the culprit in some cases. There are some cases, like this one probably is clear, you need to treat both. In many cases, in multivalvular disease, as Volkmar said, we still have very poor guidelines. Every patient is different. So having this stepwise approach from a surgeon perspective, I tell you, has been simplifying our decision.
Absolutely, and to have breathing space is really good, because we've discussed it. There's hemodynamic changes that are instantaneous, and then there's remodeling that follows weeks afterwards, and this buys you time. And this becomes a big argument when you're talking about mitral and tricuspid procedures in the same time. But definitely in our case, we had very severe aortic stenosis and very severe mitral regurgitation from MAC. So I don't think there was any doubt in our case, but generally speaking, the procedures are staged, not just to give the operators some thinking time, but the patient recovers after often the first intervention.
I have a question just for Francesco and for Volkmar. I mean, we have seen very, very good results with tendine in some cases. Usually patients are high risk with a lot of comorbidities, but the procedure is super nice, fast, and you produce a replacement. Are you willing as a surgeon to move this procedure to lower risk patients as a standard procedure? What do you think about that?
It is, so there are some drawbacks at the moment. First of all, we don't have a clear understanding of durability of tendine compared to what we have in surgical devices. Do not forget that we have excellent results with valve replacement. We should not always overcome, consistent long-term data with appealing short-term shortcuts. I believe that this device has a tremendous role in surgical patients, even in low-risk surgical patients when you have a high anatomical complexity risk. Like imagine patients who are who have a severe MAC and you want to replace this valves, this could be a very high-risk procedure. So valving MAC is going to be probably finally solved in most occasions with this approach.
Yeah.
I think we don't like to replace valves when there is a severe calcification, particularly in the elderly population. Let's be very clear. You may have valving MAC in young patients with Barlow's disease. These patients can be repaired. Mm-hmm. You can decalcify and repair the valve. Whenever the calcification is degenerative, so beyond the age of 60 and beyond, in this case, the calcium, the decalcification is a very high-risk procedure, and I think any surgeon would like to avoid that. So I don't know what is your opinion, Volkmar.
Well, first of all, I would like to get out of this position of surgery versus intervention. As far as I'm concerned, I consider this a spectrum of interventions, and surgery is one intervention that has its roles. And I also want to get out of this surgical risk assessment, because it's also, the Euroscore, if you look back on the history of the Euroscore, the way it was developed, it's not very valid. So what I think what we rather should think about is lifetime management of valvular heart disease. And I think that is something that we need to focus more on. And also mechanical valves come into play. We have seen examples this morning of mechanical valves that are in place for 30 years. And for young patients, this may still be the best option. Valve and valve is nice, but after all, the results are not that great. Likewise for valve and MAC or others. We have some problems here. And so I think we need to really think about, yes, we have a spectrum of options. Surgery is one of them. Multiple interventions, medication has become better. So that's the framework I would like to discuss these things.
If I could just add just a point to pick up on your point about lifetime management. We're very fortunate at the Brompton. We now have a patient, nearly 2 patients that are more than 8 years post-tendine. So we are starting to very slowly drip feed some information into the scientific community about the durability of these valves. And touch wood, at the moment, we've gotten some very good long-term results. But thinking about the lifetime management, what you also are doing is committing these patients to anticoagulation if they're not already on anticoagulation. And sometimes in the older population, this is, warfarin. The NOACs have not been, there's no evidence for either or, but this is a very significant morbidity associated with this type of therapeutic support of the patients post this type of device. So while the durability looks good, there are some issues with the fact that we need to support them medically afterwards.
Thank you. I think once more is the complexity of the decision making is really central in our work. I think we need to close the session. I leave Fabienne the honor of summarizing the learnings.
Yeah, thank you very much, Francesco. It was a pleasure. And I think one of the words that was pronounced most in the session was complexity in the decision making, but also anatomical complexity. And we have seen that first, we of course need to discuss in our team, and that the options that were chosen were debatable and are also been debated. But we have seen that this therapy can be applied in patients with primary MR, that we can also treat successfully and improve symptoms of patients that do not fulfill the co-op criteria. And the very nice case of Moni showed also that acute patients can also benefit of transcatheter catheter edge-to-edge repair. And finally, in the anatomical complex, patient replacement is, of course, also an option. So there are a lot of, and I hope we have shown this in our discussion, there are a lot of factors, anatomical factors playing a role in the decision of the device and of the modality of the therapy. And finally, and that's I adapted your figure, Francesco. Finally, also, of course, the experience. There were some mention of the availability of this therapy. The experience of the center play also a very important role in the choice of the device in the spectrum of the anatomical complexity. So I thank everybody very much for the nice session. And Francesco, I'll let you the last word.
Last word. The last word is I enjoyed this session very much. I think it was great to have experts around the table discussing complex cases, sharing opinions and trajectories we need to follow. I'm pretty sure that we exit this room with some good ideas and we improve our outcomes and we serve our patients. Thank you so much.
Thank you very much.